are you? We're so excited to be here for our next presentation on modifiers. We're here. I'm Jennifer McNamara. I have my special guest who I'm going to bring on in a second. But how many of you out there, just tell me real quick, how many of you love Modifier 25? I mean, we love it, right? So I'm going to introduce my special guest, Sonal Patel. I am very excited to bring her on today to talk with me about Modifier 25. Hello, Sonal.
Hey, Jennifer, how are you doing? Good to see you.
I'm doing great. I'm just so happy that you're here. I mean, it's been a
Absolutely.
minute. It's been a
Thanks
minute
for
since
having me. Yeah,
yeah. So last time we got together, it's been a minute, but we did talk about Modifier 25 on your show,
we sure
Paint the
did.
Medical Picture, right?
Right, we sure did.
Oh my goodness. Hello, everyone. I know I'm so glad to see everyone popping up here live. We really want this to be a really great session for everyone to dig in and learn about Modifier 25. We're going to be on here for 15 to 20 minutes or so, really short today, and just kind of talking about the craziness that is Modifier 25. Now, we do call Modifier 25 by a special nickname. We call it the bad boy, don't we, Sonal?
We sure do. And I think you and I have been calling him that for quite some time. He really likes to hog up the spotlight, doesn't he? One of
Yes,
those
he does.
modifiers that are always in the news. Yeah, for sure. For sure.
Absolutely, absolutely. So we want everyone to feel confident in their ability to apply Modifier 25 to a claim. And one of the things I wanted to kind of point out is some of the basic facts, first of all, about Modifier 25 that we need to understand. So when we think about Modifier 25, what are we asking it to do? We're asking it to give us more money, right? We're asking for a little extra piece of the puzzle. So we have to ask ourselves a couple questions. So I wanted to, first of all, basically show everyone some questions for consideration. So the first question I always ask myself, so now I don't know if you do, is was the procedure scheduled? Now, why do we ask that question?
Yeah, absolutely. That's one of the things that I, over the years, have seen a lot of confusion on, right? In terms of scheduling, right? That patient is coming in for the minor procedure, right? That's what's docketed inside of the schedule. And like you and I are patients as well, I thought about this conversation that I was going to have with you briefly, right? When I'm a patient, I will go in for a scheduled minor procedure, but I'm going to vent with my doctor, right? I'm going to sit and vent about some other problem that I might be having, right? And it's just going to depend on your provider. Are they going to let you vent and like not take notes, not address your new problem? If they don't, then, that's a consideration that they're just going to keep in their mind. They might schedule you to come back, but they're not going to, bill for anything separately because they didn't treat you for anything else. So that's always a really good point to keep in mind when you look at documentation, when you look at things that are on the schedule versus what is actually being documented.
Exactly. And we have regulations and we have rules like our National Correct Coding Initiative, right? CMS has given us some tips for Modifier 25. And we're not saying you have to have the same diagnosis, right? That's a guideline. You don't have to. But yes, different diagnoses do help. We understand how insurance payers process claims. A lot of times those diagnoses do drive that initial reimbursement where we may have to later appeal or fight it. But yes, it does help, but it's not required. What is required is for us to ask the second question, what was outside the pre and post work? Because remember, it is a separate identifiable service. So we need to understand the difference between that. So what to you, Sonal, is separate in your mind?
So like I was saying, if I'm going in for a scheduled procedure, right? But then I'm also complaining about something else. Separate, significantly identifiable, right? Is the physician or the APP documenting what my secondary complaint is actually about? That's the key factor when you're appropriately appending Modifier 25. And this whole conversation and prior conversations that you and I have had has been about the fact that it's the documentation that's just not supporting that appendage of the modifier. So yeah, I mean, it has to be identified as something separate and significant, and it has to be worked up, right? And these
Yeah.
new guidelines in 21, I think definitely should be helping our providers out, because it literally says that the problem has to be addressed. So that's the only way that we can give credit for an E&M, is if that problem is being addressed, if it's being treated, if it's being worked up, if the patient is leaving the office with a prescription for that, secondary problem, etc. So, yeah.
Agreed. And so another thing I wanted to point out is, you work in compliance. I occasionally handle compliance concerns. And it's always that question, what is the risk? So in my experience over the last 20 years, when I started to learn more about Modifier 25 as I was growing in the industry, I would see a lot of ways that physicians would add it, why they would add it. And sometimes it was like, oh, that's the way I've always done it. Or someone told me to do it, so the claim go through. I'm like, are those good reasons? I don't think so. Like, do you really understand what it's for? And the risk that's involved, we've seen over the last at least couple years, especially recently, with a lot of the payers cracking down on this. And they're the ones paying the bill. And I want to kind of stop and kind of have everyone think about this. You are asking for a third party to pay for your service. So it's either the patient paying for it or it's the insurance. And like any other, business that you have business, you don't just pay things without looking at it first, right? You don't open up a bill you get in the mail and say, hey, I'm just going to slap a check in here and pay this. I'm not going to look at it. Of course, they're going to know why they're paying for something. And they've given us guidelines. They've given us documentation requirements. So on the list here, Sanal, you can pick maybe one or two of these that you want to talk about as far as the risk that's involved in ignoring these guidelines.
Yeah, absolutely. Right. From a compliance standpoint, that really has to be our overarching kind of criterion and our overarching job as coding and billing professionals, auditing professionals, right? We have to really take a more comprehensive stance in the work that we do. And that starts and centers around compliance. So when we make a snafu or two on appending the big bad boy, just one or two, not a big deal, right? But when we see volumes of the data, which we have access to as providers, right? So when I go in from a compliance standpoint, I want them to take a look at their data, right? It's theirs, they generate it, but the payers have always taken the lead, have taken the upper hand over all of this time, because they're the ones who are critically looking at the data. So when it comes to the volume, more than two of the big bad boys appended, say there's like 1,000, 2,000 in a month that are added to your service lines, right? That's a problem. We really want you to, appoint someone on your team, come to people on the outside like myself, go in and look under the hood, right? Take that preventive approach to avoid these egregious demand letters that will come to you eventually when the auditors on the payer side are looking deeper. So I think best practice is always to go ahead and take that preventive approach by doing your education and doing your post-audit education, so you actually understand and eliminate the misunderstanding and confusion that has been going on with Modifier 25 since like 1995. How long has it been? It's been forever.
A long time. I mean, we always go, yeah.
Time ago. Yeah. It's been
forever.
Yeah, for sure.
Forever ago. And yeah, I think we always point to the OIG, audit they did back in 2005-ish. Yes. Right. And so that was a long time ago. I mean, I was just newly married. I will be married 20 years next year. So I think about in longevity that way, like that's how long it's been a problem.
That's right.
So yeah, so it's crazy. But when it mentions the complexity of coding, one of the things I think of too, because I know you do audits and I do audits in different specialties, I mostly live in the surgical world.
Yep.
But at times I do touch on primary care and other types of specialties. I mostly do ortho, general surgery, ophthalmology, and there are different complexities and nuances with adding modifier 25, and even oncology when I've had my hands on that. Like you have infusions, you have other types of diagnostic services. So one of the things I wanted to point out too is when we think about the scope and the necessity of certain services. So you have to think about what you're doing from a specialty standpoint. A lot of times you may not always write a prescription. So you think about what else you're doing, right? You may not always
The risks. Right.
provide surgery or a procedure, and you may not always recommend diagnostic treatment. And maybe it's just a very simple visit.
Right.
I don't know if you remember, this is a while ago on one of the Compliance Guy episodes. Shout out to Sean Weiss and the Compliance Guy. But there was an episode where he talked about using Modifier 25 with like a level 2 visit. And not that if you have the criteria, the medical necessity, great. But in my opinion, and I agree with him in some ways, that there is very little evidence in many of the level 2s to support medical necessity for an additional procedure. I mean, like it's very hard for me to think of a level 2 with a modifier 25 where the medical necessity is going to be there. You're going to have a separate condition. You're going to have additional risk data, right? If it's a level 2. What is your thought about that? I mean, from a medical necessity standpoint, we think about what's really appropriate. We may have the elements, but is it medically necessary?
Exactly. Right. So just like how I was talking about ourselves, our overarching criterion, right, is compliance should be central. From a payer's standpoint, everything that they're looking at for our provider services has to require medical necessity. So yeah, I have not seen a situation like that. So I would need to look at the greater diagnoses, what the problem is with the patient, to make an opinion statement. But just from the generic stance of a level 2, in addition to a minor procedure, yeah, I'm not really sure if that would actually, warrant something separate and distinct in terms of the medical necessity as well. So
Exactly.
yeah,
I would just, my caution is just to be careful that you have truly carved out. Like I say, carve out. I like to also use the illustration of an ice cream scoop, like if I'm taking the last couple scoops out of my carton of ice cream and like, what do I have left over? Because I'm like, is there anything left to really, really work with here? So like, I think about, you have your problem that's been already addressed as the reason for your procedure. You have to address that problem. And while you're in the room with the patient, you're like, and like Betty Hovey always says, your physician's not going to just walk into the room and start carving into your arm and do a biopsy. They're going to ask you some questions, right? So that is all part of pre and post workup that was required to make a decision on doing it. Outside of that, have a conversation, discuss additional things you have to do. And that could be medication. It could be having additional procedures, diagnostic testing. There has to be something else. So I say, get out your little table, get out that, there's a lot of audit sheets out there. I'm not really a big fan of all these different tools, although I like Novitas's electronic tool.
Yes,
but I will say, just get out the actual table from the AMA. It's super easy. Just circle what you have where it falls and then draw your lines and you're good. But at the same time, think about the medical necessity of it. And when you're doing a prescription drug management, if you're going to use that, make sure you're actually managing it. Make sure you're actually offering it a recommendation. You're documenting what medication it is, not just I filled these prescriptions today. Why did you fill them? Make that connection to the problem you're addressing.
Yes, absolutely. Absolutely. And I think those new guidelines that we have now are a good thing, right? It's a sigh of relief that our providers can actually go back to using their words, which we know they can do, right? I know it's that EMR system that's kind of, created a little bit of a mess between the old guidelines and these. And so we have to continue imparting the message that we need to see their words in terms of continuing the medication with this dosage discontinuing that medication because of this, that, or the other rationale. It can't just be the old templates of continuing the medication and that laundry list of like 15 drugs, which we know that the patient is not currently on, right? Those are 15 drugs from years past that were just assembled into a nice column in the old EMR construct. So there's a lot that needs to be cleaned up in the EMRs as well. I know that's a tangent, but in terms of the Modifier 25 being used appropriately for that last column of risk for the med management is really, really crucial.
Absolutely. And, I wanted to, as people know, the reason we're coming on here and giving these little snippets of education is because we're trying to whet your appetite for our upcoming modifier tour. So I wanted to let everyone know that we are going to be, if you listened last week, you probably already heard all the fun stuff that we're going to be doing in the future. But if you missed it, this is just a little bit of a preview of what you're going to see coming up. Dallas, Texas is our first location, October 27th. It's going to be an all-day event, but we'll have 2 sessions, a morning session, afternoon session. So if you're working that day, you don't have to worry about taking the whole day off. You can come in the morning, the afternoon. Your manager will love that. They can have you a little bit of the day, and you can get some education. It does come with 3 CEUs, so you can have that 3-hour education plus your units there. There's a QR code there for you to scan. And the nice thing is right now we are offering $10 off the tuition. So you, or the registration. So you can actually have a little bit of a discount there. Keep in mind, this does expire on the 1st. So please hurry up and grab your extra coupon so you can get the extra deal off. It does apply to all the sessions that are coming. So we do have Dallas, Texas. And if you're paying attention at the bottom of the screen, you're going to see also we're coming to Florida in December.
Nice.
We're looking for a location in Tampa area on the west side currently. And then St. Louis is one of my favorite cities, and I'm not far from there. So I was really excited to add St. Louis to the list at the St. Louis Zoo. So I'm really excited to get to go to the zoo and do my education there. Super fun. So I wanted to point that out. But I really just want to also highlight, you mentioned something about technology and EMRs, and that's my focus lately. A lot of us, our focus is helping practices understand the detriment they're putting themselves under by not setting up their EMRs appropriately, understanding what they do on their behalf, and behind the scenes what can happen if we're not careful in how we set them up. What are some of the things you've noticed that contribute to inefficient processes, especially with Modifier 25? EMRs have created a lot of issues.
Oh, absolutely. I mean, the EMRs have definitely, it's just the way they have been constructed, right? And I do get a lot of pushback from our providers in terms of the cost that original EMR, was created for, right? Way back in the day, they had to, and the cost was so much. And now these types of companies are stating it's going to be an additional cost, right, to tweak the templates, et cetera. And so there's been a little bit of pushback in terms of using the budget to go ahead and implement change in the various EMRs that they have used throughout the country. So it's kind of sad, but I think we do have to continue messaging that it's hurting their practices. And now times have changed. Flash forward, new guidelines require new templates, new constructs, et cetera, to help them collect appropriate reimbursement instead of being penalized unnecessarily.
Wonderful. Yes, absolutely. We have to think about the risk involved in when we take on a software like that, understanding how it can affect our bottom line and affect our revenue. I do have, we're going to have a couple questions we'll answer. We have a few minutes left. We'll just go ahead and answer a couple questions here. Just on a basic level, we don't have your documentation in front of us, so we can't give you a definitive answer legally, of course, but I will kind of address some of these. So what happens when a patient comes in for a consultation and the provider decides they need a minor procedure right then at the encounter? Does the provider bill for the consultation and then the procedure? This has always confused me. Well, thank you, Jamie, for that question. I will say, if you really look at your NCCI guidelines, we have the rule that just because they're a new patient or it's the first time they're seeing them doesn't necessarily mean you always end Modifier 25, but it doesn't mean you can't. You really have to think about the purpose of 25. They have to call out for you, right? Those differences, those nuances, what is separate from the procedure. So like I said, carve it out. What did you use for that diagnosis, for that procedure? What's the reason you're doing it? Did you discuss anything outside of what's normal for that procedure? Oftentimes you are going to be considering multiple things in a consultation service, because the first time you're seeing that patient, you need to get to know them a little better. You're going to ask them questions. You may have to order some additional testing in addition to the procedure. What do you want to say about this, Sanal, on a basic level?
Exactly. No, I support everything that you stated. I'm a big believer in carving out the separate details. And if there are things that are left over when you carve it out, if it's going to be separate and significant, that's when you can consider counting it. But yeah, it has to be done as a carve out individually from consultation to consultation. So yeah, for sure.
I agree 100%. And we would love to be right there with you, looking at your charts with you. And, we would love to help you out here, but we also want to give you the tools and resources that you need to be successful. So like, get out the NCCI manual, get to know Modifier 25 from a payer perspective. Also get out your policies from Cigna, Aetna, United Healthcare, all of your commercial carriers. They have sometimes their own nuances. Sometimes they'll give you tips on documentation, which is really helpful. And so I want to kind of point that out. Now, I mentioned earlier specialties. I'm going to go ahead and post this question here. I don't have the ability to answer you 100%. I don't answer questions on if I will bill this way or not bill this way. What I will tell you is, again, same situation. I think a lot of times in ENT, because I do audit ENT occasionally, that sometimes we overthink it and we think we can't get a 25 when sometimes we can. Dermatology is another specialty too, where they do minor procedures a lot. And I think sometimes they shortchange themselves when using it when they can. But again, those are just examples on that, the AMA sheet. They give you examples of what is a risk or what is data, right? But on the risk side, they don't give you a full inclusive list, right, of the risk to the patient. So what are some tips you can say, Sanal, things to look for outside of medication or surgery that can help them make a decision on if there truly is something to carve out?
Yeah, well, for this particular question, it's about a new patient, right? So we have to be careful and always identify who the payer is, right? If this is a Medicare patient, we have to be mindful and look at our CCI edits, our NCCI, and read closely what the fine print is there for new patient and Modifier 25. Is it actually warranted? And then, of course, you got to identify if this also is a commercial patient. And so you got to go digging and hunting for the Blues or the Cignas and their policies, and really, really take the time to identify. Because again, it's the payer that's going to be reimbursing you, right? Not CPT. It's not the AMA that's going to cut you that check.
Yes.
So just because the AMA says something doesn't mean the payer does what the AMA says.
Exactly.
So keep that in mind. Yeah.
Yeah, no, I totally agree. And that's the one thing I always point out too is that, they are paying the bill. And there are times when Medicare does not agree with the AMA. Lots of times, even in the final rule, we have so many examples of, you know what, we don't agree, we're giving you a new code. So it happens all the time. So we have to be aware of that. I also want to point out we know what Cigna tried to do a couple times recently with Modifier 25 on established patient visits. Now, I don't know how comfortable our audience is in understanding, your encoders are great, but all that information comes from the Medicare files that your encoders have. There's what's called a PTP edit file, procedure to procedure edit. Now we're used to our encoders telling us the top code is payable, the bottom code might need a modifier, maybe, right? Indicators. And that's where that comes from. So if your E&M code is in the second column or the bottom line there in your encoder, that means that is the code that gets a modifier. If you type in like a 99203 with a minor procedure or a major procedure, whatever it is, a minor procedure, and you don't get an edit, you don't need a modifier. And so I wanted to newsflash, you don't need one. Why are we putting it on there?
Right.
So
Exactly. Oh, wow. That's another
yeah,
whole conversation that we could have on the volume of the modifiers that are just appended for no reason, right? If
no,
you do that CCI cross check, there was no need for it to begin with.
no.
So you're already causing additional eyeballs on you when it was not even necessary, right? So lots of things to think about in terms of our resources, our tools, that we should be utilizing every time we're sending claims out the door.
Absolutely. And I wanted to let everyone know too, Sanal is going to be one of our featured speakers at the upcoming CDI awareness conference on compliance in our outpatient settings for CDI. And the reason I'm pointing this out is because it's so important. A lot of what we look at with our documentation is clinical indicator based. And if we can really capture the clinical indicators and identify where the nuances are for our physicians. They order a test or they prescribe a medication. What's the clinical reason for doing so? Is that validated? And it's starting to come out more in the outpatient setting, and a lot of payers are looking deeply at documentation, even though they're not using exam, right, in your
Mhm.
leveling. They are looking at it from a medical necessity standpoint. If you didn't examine this body part, how did you diagnose them with this condition?
That's right.
And it's a big deal. And so that could also affect your ability to get additional procedures and E&Ms together if your medical necessity, your clinical indicators aren't there.
Exactly.
So I'm looking forward to your session on compliance and documentations and
Me
all.
too.
So definitely check it out, guys. Go to our website at healthcareinspiredllc.com under our event section, and you'll be able to get some additional information about our upcoming events, especially our upcoming conferences. We do have, of course, our conference coming up on CDI, then we have practice management, and then we have primary care, and then in the spring we have dermatology. So we
That's
look forward
awesome.
to having you with us for those conferences, either virtually or you can watch them on demand later on throughout the year. Well, thank you, Sanal, for joining us for this wonderful day session on Modifier 25. And we thank our attendees for coming and listening to us talk about the bad boy Modifier 25. Is there anything you want to leave our audience with, Sanal? Other places they can find you?
Well, you know what? Thank you so much for having me. I hope our audience today had a good taste of what your sessions are going to be throughout the country, starting with Dallas, Texas. So it's incredibly exciting. And hopefully one day you can come out to Chicago. It would be great if we could do it together here, up here in Chicagoland. So it's awesome.
Well, I look forward to making that happen. We thank you for
Yep.
joining us, and we're going to be back in a
Absolutely.
couple weeks. Guys. I'm going to New Orleans with Miss Christine Hall next week. We're going to be at the Healthcare Advocate Summit, so I won't be on next week. But the week after that, we have Modifier 59 with Pam Vanderbilt. So stay tuned
Awesome.
for that. Thank you guys for attending. You have a wonderful day.
Thanks so much.